Welcome to this final day of the Align MNH April Collective. My name is Dr. Anshu Banerjee, and I'm the Director of the Department of Maternal, Newborn, Child and Adolescent Health at the WHO. I'm pleased to be moderating this exciting and critical session entitled Improving Quality of Care for Impact. We are excited to present an engaging conversation on quality of care today between key experts in this field from around the world. First, a few housekeeping points. We will be active on social media throughout the proceedings and welcome you to be engaged. The April Collective hashtags are #April22Collective and #Road to 2023. You will notice that we have simultaneous translation occurring from English to French. If you wish to hear the session in French, please click the link below the video player on this page. We encourage you to use the chat function for comments and questions throughout the session. It is located immediately to the right of your video player, and you can use it to type in any questions you may have for speakers. If you have any technical questions or need support, please click on the red circular word bubble in the bottom right of your screen to open the #help chat and access support from the technical team. We'll be using various interactive elements during this session and encourage your participation. When a prompt becomes available, you will see a note in the chat directing you to scroll down the page you are currently on to view and respond. When the tool is active, please use your mouse and keyboard to respond to the prompt directly in the box in which it appears. The tools will update in real time as you and your fellow participants interact with them. To get us started, we'd like to ask you to answer a question telling us where you are joining today's session from. Simply scroll down on the same page, on the same session page, and click the plus button and enter in your information to participate. I would now like to introduce our opening speaker, Dr. Amy Pollak. Dr. Pollak is Director for Maternal, Newborn and Child Health at the Bill and Melinda Gates Foundation, where she leads the development and execution of the team's overall strategy. She oversees the program's grant portfolio and works closely with internal partners and peers to coordinate efforts to achieve the program's goals. Amy has over 25 years of experience in domestic and international healthcare, and we welcome her to our virtual stage. Dr. Pollak, over to you.
Great. Thank you so much, Anshu, and good morning, good afternoon, and good evening to my fellow colleagues. And for those who I haven't had the pleasure of meeting, I hope to meet you soon, maybe even in person. So as Dr. Banerjee said, my name's Amy Pollak. I'm the Senior Director for Maternal, Newborn and Child Health, overseeing family planning and nutrition also at the Bill and Melinda Gates Foundation. And it's great to be here with you today virtually and to learn from you as true leaders driving the progress to improve quality of care in maternal and newborn health around the world. So I also want to thank you at Align MNH and the organizers for making this event possible and for inviting me to briefly share my thoughts on the importance of quality of care for women, a topic that I've seen evolve and shift in some, but perhaps not quite enough ways throughout my years serving as an obstetrician in public health and now in my current role at the Gates Foundation. So take a deep breath with me, please, as we recognize that we're in the third year of a global pandemic that has upended health systems across the world. And we are contending with new global crises unfolding in Europe, all of which have had an outsized impact on who else but women and girls. Roughly 10,000 more women are dying each month in low and middle income countries than before the pandemic, due to specific COVID-related disruptions. And we all know that no matter how adverse the circumstances, women do, and always will, still get pregnant and still need to deliver those babies. These new and complex challenges compound the ongoing challenge of delivering good care to pregnant women. A daunting challenge even before the pandemic, as we all know. I think we're all feeling an urgency right now to do something different, something innovative, to change the current state of weak, non-resilient systems that fail to provide essential services for women and newborns. At the Gates Foundation, we continue to prioritize not only access, but improved quality of care to increase the number of women and newborns who receive the support they need to survive and remain healthy before, during, and after childbirth. This is important both for achieving mortality reductions, but as we've heard from other speakers during the last few days, we need to improve women's experience in healthcare settings overall, or we can't expect them to attend clinics and attend the facility for a delivery that could be high risk. In the context of an audience of fiscally constrained governments and decision makers who need to prioritize like never before, we, along with our partners and grantees, are elevating proven and cost-effective interventions that can really make a difference. What are the interventions we need to focus on? Women need respectful care from skilled birth attendants. Midwifery is an incredibly effective and proven part of the healthcare workforce in terms of meeting the unique needs of women and providing an improved continuum of care, which we all know makes a big difference. I was taken by the data in the 2021 State of the World's Midwifery Report that found that a full package of midwifery services, including family planning, can avert 83% of all maternal deaths, stillbirths, and newborn deaths. Scaling up to universal coverage of midwife-delivered interventions could save 4.3 million lives by 2035. So we do know a lot about what to do, yet despite this global recognition, midwives account for less than 10% of the global health workforce, and they continue to be undervalued and under-resourced. More than half of all midwife training programs have closed during the pandemic, preventing the next generation of healthcare leaders from getting the education and the training that they need to do a great job. With International Day of the Midwife on the horizon, we're working alongside partners like the International Confederation of Midwives, the White Ribbon Alliance, and others to amplify midwives' voices and to elevate midwifery on the global agenda. By growing and strengthening the midwifery workforce, we can make critical progress for gender equality and women's leadership in global health while ultimately delivering better care. Investing in midwife is critical, but still there are other opportunities to accelerate change. We're investing in a range of evidence-based practices, from maternal nutrition interventions, so important as we learn more about the impact on low birth weight, and to kangaroo mother care to improve the quality of care holistically. Simpler interventions than one would expect to make a huge difference. Investing in midwifery is critical, but still there are other opportunities to accelerate change. We're investing in a range of evidence-based practices, as I said. So I'm eager to learn from your experiences and approaches for improving care for women and newborns in this convening, as well as in the upcoming International Maternal Newborn Health Conference that we're looking forward to, hopefully in person, in 2023. These critical gatherings provide meaningful opportunities for our community to build a more effective and focused environment for achieving the SDGs and in creating the reality that healthy mothers can deliver healthy newborns. As a collective community, we need to accelerate progress by using our loudest voices, couched by the evidence we have, to lead the way. And we need a crusade, a real crusade now. So thank you for joining us here today as part of this crusade to learn from our esteemed members of this panel about improving quality of care for all women and newborns. Back to you, Dr. Banerjee.
Thank you very much, Amy, and particularly for highlighting the need for respectful maternity care, for the role that midwives can play, and for the role of quality of care. It is now my honor to introduce the panelists for today's exciting live global town hall. We will have matron Margaret Manna, and she is a Sierra Leonean midwife with over 30 years of midwifery experience at clinical, academic, and public health institutions. Margaret is a driving force for quality of care in Sierra Leone and is currently program manager for the National Quality Management Program, the first quality management role the country has had. We also have Dr. Gagan Gupta, and he is a senior advisor of maternal and newborn health at UNICEF headquarters. A neonatologist and pediatrician, Dr. Gagan brings more than 20 years of experience working in public health and has been providing support to countries for quality maternal and newborn health services. We have Dr. Mike English, who works as part of the Kemri Wellcome Trust Research Program in collaboration with the Ministry of Health and a wide set of national and international collaborators in Kenya. Dr. English is a pediatrician who has worked in Kenya for over 20 years, focused predominantly on improving care in African district hospitals. We have Professor Grace Irimu. She is a pediatrician and the chairperson of the Department of Pediatrics and Child Health at the University of Nairobi. She is a health systems researcher with expertise in developing and disseminating evidence-based clinical practice guidelines and improving their uptake. And finally, we'll also have Dr. Kathleen Hill, and she is a family physician with over 20 years of health systems service delivery and quality improvement experience in low, middle, and high income settings. In her role as Senior Technical Advisor for Quality for JPIGO and USAID's Momentum Country and Global Leadership Program, she works closely with colleagues, Ministry of Health, and country counterparts to support systems-wide improvement of people-centered healthcare services. I'm now going to ask my esteemed panelists some questions. We know that it takes a whole system to realize quality, and that this is one of the key findings from the work to advance quality care for maternal newborn child health to date. Actions to implement a systems-wide quality of care approach is necessary to sustain continuous improvement of maternal and newborn health services. Matron Manna, I would like to start by asking you, what are some of the key lessons learned in the efforts to build and strengthen quality of care, health governance and management structures at national and at subnational levels to sustain maternal newborn health quality of care actions from your experiences in Sierra Leone?
Good morning, everyone, and thank you very much for that wonderful introduction. So firstly, I will start by saying Sierra Leone, a lot of partners, including some of you today on this panel, did a lot of investment in maternal newborn health, and also, but Sierra Leone is still crumbling with being the countries with one of the highest maternal mortality in the world. So in terms of lessons that we learned was to build a business case wherein an assessment was done in the RMNCH profile, and one of the key contributing factors for the increase in maternal and newborn poor indicators was alluded to poor quality of care. So from that level, we had to advocate and lobby for political buy-in and political will. So with strong political will, His Excellency the President actually approached WHO for Sierra Leone to be among the countries within the QED network. So that was one of the lessons. When you have a strong political will and commitment, So they had to ensure that Sierra Leone was among the QED. So at this point, I really want to say thank you for that opportunity. Secondly, in terms of policy environment in country, we had to work together to develop a policy that can clearly show what the national priorities will be in terms of quality of care and quality improvement, as well as the roadmap. So the roadmap has activities and an M&E framework wherein we measure as we go. So the roadmap clearly had activities starting from national to district as well as community level. So that is our guide. From there, we had clear leadership structures from national. At national level, we have two key governance structures. One is the steering committee, and the second one was the technical working group. The steering committee actually comprised of all key stakeholders, directors, and it is chaired by the Honorable Minister of Health or the Chief Medical Officer. Then the director for RCH is the secretary to that governance body. For me, I only sit in as the technical person in case there are technical things that they really want me to throw light that people will want to know the nitty-gritty. Then we have the technical working group, which is comprised mainly of technical people, all partners, including UN agencies. We have the civil society, we have the human rights, then we have the academia and research bodies. In that committee, we discuss technical issues in terms of even any activity in terms of quality of care that we want to do. That's the body that discusses, and the way forward is moved to the director RCH. So that particular body is chaired by the RCH director, and I am the secretary to that committee. And we purposely made sure that every month, be COVID, no COVID, that particular meeting is held on that day. So no excuse. Additionally, Sierra Leone went forward because we've been training people, the QOC coaches, and there's a lot of attrition. So what we did was to also advocate, and the Ministry of Health, the Chief Medical Officer, actually requested all facilities and district medical officers through the medical superintendents and matron to appoint dedicated salary QOC officers that we have today. So in every district, you have a QOC officer within the district health management team, as well as the hospital. And these officers, we did not create a prior committee. We have QOC committees at each district and in each facility. So the existing management structures that we have the hospital management committee, the QOC officer sits in and drives the quality of care agenda within. So discuss everything around quality of care, as well as within the district health management team. These meetings are held on a monthly basis. Then at subnational, every facility, even within the community, like the PHUs, we have the QI committees. So our management structure starts from national as well as community level. Then what we have done was to develop clear enforceable terms of references. So the steering committee, they have their terms of reference, what they are supposed to do, because we don't want people to be in meetings that they don't know exactly what to do. The TWG, they have their own TORs, and also the QOC officers, they have got their own terms of references. Additionally, what we did was to develop tools, monitoring tools, and we are doing joint monitoring together with all partners. We have done partner mapping. We know where partners are, and we have linked them to these QOC officers at community as well as facility level, as well as district level. So now, every year what I do was to develop the national priorities out. I extract it from the roadmap and I share with partners, so it is now aligned within their work plans. So I share that with them for them to know exactly, and I track from this level. So whatever implementation is there, I make sure my office is represented and we go together. So these are some of the governance structures that we have done, and we are tracking it. Then we have created a dashboard within the DHIS2, the QOC dashboard. It is tracking on performance of facilities. And most often we have learning sessions at district level and at facility level. What we have now tried to do is to see how we bring regions together so they share best practices and experience. Then last year, we held our first ever national conference on quality of care, where we displayed QI projects that we are doing and also some of the lessons that we have learned. So out of that, we have developed our implementation package to really tackle on the key mortality, the conditions that actually cause maternal deaths as well as newborn and child. So that implementation package is now available, and that is, we are now about in the process of rolling it up. However, with all this that we have done, we still have some teething challenges, but that will come maybe later on as a question that I'll ask other people to share their experiences. So basically, these are some of the things that we have done as a country, and that is helping us in moving the QOC agenda from national to sub-national levels. Thank you.
Thank you very much, Matron Margaret. And you can maybe quickly highlight how you ensure that your partners, because you've highlighted that you have a plan, how they align their resources around your common goals and activities. A very short answer to that one.
Okay, thank you very much. So like I said initially, every year I prioritize what we should do from the extract from our policy as well as the roadmap that we have done. So that one I share with all partners within the technical working group. So once I share it with them, I tell them this is the national priority and this is what the Ministry of Health and Sanitation wants to invest in, so that we get. So every partner now takes this to their organization. Then when they take it to the organization, they also give me feedback on the areas that they think they can and they have resources to do. So we develop a common work plan. Once we develop, we also cost that work plan, they budget to it with timelines. So before every activity is done, they will also come again to me, then we plan together. As you know, Sierra Leone, we are benefiting actually from partners within the country. So out of the partner mapping, I now share this work plan with the district DMOs and the medical superintendents and also the QOC officers. Then the QOC officers, each and every committee within the district that has existed, like we have the MDSR committee, the QOC officer is part of that MDSR committee. So whatever activity that they are going to do, it is aligned with its agenda. And a joint supportive supervision is also done. First from implementation to monitoring.
Thank you. Thank you very much. We'll now go to the second speaker, and that is Gagan Gupta from UNICEF. Gagan, maybe you can reflect on what are critical components needed to scale up small and sick newborn care for quality.
Thank you. Thanks, Anshu, and greetings to all of you from UNICEF. I'm Gagan from the UNICEF headquarters team, but currently I'm speaking from Abuja. So there are 10 critical components for scaling up small and sick newborn care with quality. And these are pretty much aligned with the 8 quality of care framework components and also the health system building blocks. Now, I will go through a bit in detail of few of them, but the first and the foremost is the country leadership with a clear national vision and a plan. In absence of it, we will start with pilots and end up with pilots. It's like a journey. You need to plan it well, and you need to know where you want to go. And along the way, you have the milestones that you have to achieve. It may take 5 years, it may take 6 years, but what's important is to have a clear roadmap for the country. And the countries which have done it well, like India, Bangladesh, then Sierra Leone, Malawi, Ghana, they all had a very strong national leadership, a clear long-term vision, and also equally important is strong partner support on the ground. Another mistake which we do is we start with coverage, and quality often comes as an afterthought. Quality has to go hand in hand with coverage. It cannot just be a footnote in the planning. The second important thing after the country leadership and a national vision is financing. Now, financing needs to be adequate and sustainable. It can be either a fully domestic financing or it can be a mix of domestic and government financing, domestic and partner financing. The second important thing is we need to pool all the resources. These resources can be coming either from the partners or from the government. But what is important is even if the partners are funding it, the transition has to be gradual. It cannot be a sudden transition because it can impact quality big time. The third important issue is human resources. For human resources, there is no easy fix, but there is also no getting away from it. And in the next part of this, I will speak a bit more on the human resources. The fourth important component is equipment. Now, it's very easy to provide equipment, but difficult to sustain and maintain. And here again, countries like Malawi, countries like Sierra Leone, they have done very good work on the biomedical engineers and sustaining the equipment. But it is also important to build the domestic capacity for equipment. The fifth important thing is the infrastructure. In terms of the infrastructure, we need to make sure it is adequate and includes important things like WASH, infection prevention and control, which have huge impact on the quality. And then comes the data systems, because we need to know what's happening in these units as well. And I will speak a bit more about the data systems as well. And the last four components, which I will just give a passing reference, is the care after discharge, the labor room care, the engagement of the families, and last but not the least is the referral. So over to you, Anshu.
Thank you very much, Gagan. And so maybe you could just highlight a bit more in detail, what are the major determinants of quality in sick newborn care units?
Right, so I will focus on two major determinants. The first and the foremost is the human resources. And as I said, there is no getting away from human resources. It's not an easy fix. It's a difficult thing, but we have to plan for it. And the first important thing is we need to get out of our mind that it is not possible to get human resources. We need to factor in the adequate human resources within the plans. Once we have done this, we need to adapt the policies to attract and retain the human resources. And here, India has done some tremendous work. They changed the human resource policy. First of all, they created the positions of the pediatricians, the nurses, the lab technicians in the unit, and then they adapted their policy to attract and retain them. The first and the foremost thing they did was they made these positions a part of the district plan. The second thing was they also opened up the walk-in interviews. Often it happens is when we need people, they're available, but the job vacancies are not available. The third thing was to make difficult area allowances to attract people in the difficult to serve duty places. Also, the time-bound regularization of the contractual staff and ensuring there is no rotation of the trained staff. I will give you an example of Sierra Leone. I was there last month. In the 4 districts I visited, there were 4,000 community nurses who were working in the hospitals, and large number of them were working in newborn care unit. But they were working as volunteers awaiting the regularization. So if the partners can pool their resources to the domestic pool, probably this can happen much, much faster. The second important thing is the data systems. Now, you need to know what's happening in these units. You need to record what's happening, you need to analyze it, and you need to use the data to provide the feedback. So what is important is all the units need to record the same variables. And Bangladesh has done it, India has done it, Malawi has done it. The second important thing is you need a system which can use this data and analyze it and give you information and readily visible graphs on certain parameters. And third is how do you use within the unit in your death reviews, and how do you use this data to provide the feedback back to the districts, and lastly, prioritize your resources for supportive supervision. Because often the resources for supportive supervision are limited, but the worst performing units can be prioritized looking at the data in terms of mortality, in terms of outcomes. So in all, what's important is we have a system to capture data, to analyze data, and to complete the feedback loop of the data. So to summarize, the two most important components to me are the human resources and the data systems. Combined together, they would really help in building the quality in the services. Thank you so much.
Thank you, Gagan. We will now take a few minutes to ask for audience participation with a key question. It is right on this session page. It's right on the page you are on, and you simply can scroll down to below this video to access it. We know that a high-quality health system is one that is capable to respond to crisis while being able to maintain essential health services with quality. The response to the COVID-19 pandemic has demonstrated that while maintaining essential services was prioritized, the quality of services was not always part of it. So our ask to you as the audience is, list some critical actions health systems must adopt to ensure essential quality maternal newborn health services continue in the face of crises. You'll notice that there are 4 columns around leadership, learning, action, and accountability. Click on the white plus box below the column category, your response of critical actions health systems must adopt to ensure essential quality maternal health services continue in the face of the crisis fits under. This being either leadership, learning, action, or accountability. You can post your response by clicking Publish. You are also welcome to submit more than one response. All of these instructions are also in the chat. The question will remain open for input until the end of this session, and we will come back to them later in this session to reflect on your valuable inputs. While each of you do that, I would like to continue with our panel discussion. Shared learning is essential for enhancing the implementation of maternal newborn health quality of care interventions and quality improvements at the subnational, district level, and point of care. Using learning is a key mechanism to support the scaling up of good practices and innovations. Mike, what can we learn from considering organizational theory that helps us understand how to develop maternal newborn health quality improvement learning strategies so they can be embedded in systems?
Thank you, Anshu, and it's a pleasure to be here with many illustrious colleagues and a pleasure to hope to be talking to people around the world. Let me maybe just start with a story. So the story is, imagine yourself on a health facility that you know well, that provides delivery care to women, provides care for a sick baby if their baby gets sick. I'm sure you're all familiar with those settings. So imagine yourself there and think of a cleaner that's in one of those facilities, perhaps working on the postnatal ward, and the cleaner sees a worried mother and what they think is a very sick-looking baby. And this cleaner walks quickly to see the nurse to explain, but the nurse says she's rushing to theatre. And so she asks the cleaner, "Why don't you call the doctor?" The question for you to think about is, would the cleaner in the facilities that you know well feel comfortable to call the doctor? Would the doctor in the facilities you know listen to a cleaner? Often quality and safety are thought of as only part of specific projects. We have a quality of care officer or a quality and assurance team. But these specific, when thought of as specific projects, they may not address the issues I've just outlined in the story. And that's really what needs to change. Quality and safety need to become part of the DNA of organizations and facilities. And that means the teams that make things work. We need everybody all of the time to be thinking, how can I make things better or safer for the people I'm looking after, but also for my colleagues? And what this means is changing organizational culture, because we need to get everybody involved, from those who clean, as I've highlighted, to those who are leading the facility and even the policymakers. And high quality care with everybody involved in the team is about trust. It's about people trusting that they will be respected, that they will be looked after, and that all of us are doing our best. And that's about effective communication. I illustrated that the doctor needs to have sufficient respect for the cleaner to listen to their concerns. But it also means that people feel comfortable to step up and fill gaps that they see, which happens all the time in healthcare. When a small problem happens, somebody might need to pick up the pieces and address it so that we don't get a major problem. And that's part of the thinking around critical incidents and what prevents them from turning into disasters. But what we're talking about here is the day-to-day reality of resilience. And you do not get resilience in a health system without everybody working together and doing their best. And obviously what this means is that it's the styles of leadership and management that are critical. It's no good just having a top-down command structure which says everybody must do something. We know that that doesn't work. So we need to think carefully about leadership and management, and we need to get rid of blame and turn the conversation to things that are more positive. We heard about the need for many more midwives, and I absolutely agree. But we also need to break down the barriers between different professions and the territories that they often operate in, so that a midwife will feel that they aren't involved in the postnatal care of a baby, or a nurse no longer feels that they can tackle an issue because it's a job for somebody else. We do need to have proper skills and regulation, but we also need to have a system that is flexible and resilient. And I fully agree with Dr. Gagan's comment that for those who are running health systems, understaffing is perhaps the biggest killer of quality. Because when there are too few staff and they're constantly under pressure, they get overwhelmed, it causes burnout, and they no longer feel able to contribute to quality of care. And even the best teams in the world cannot compensate when there are simply too few people around to do the job. So my perspective is that we do need to think about what people often call the software parts of the health system as much as we think about the hardware parts. But let me stop there and pass back to you, Anshu. Over.
Thanks, Mike. And while people are still filling in the questions, let's say, maybe you could reflect on your own experience and learning from building maternal newborn health implementation research into quality improvement processes at districts and facilities. So can you describe some of those experiences, Mike?
Thanks, Anshu. Yes, and obviously I'm speaking on behalf of many colleagues that I've worked with in Kenya over many years. And I think the first thing to say is that we started with a very deliberate strategy to integrate implementation research into everything that we do. We didn't think of it as something we would come back to later. And we also didn't think of it as an academic exercise. It's not, to do the implementation research is not the end result. The implementation research is a means to do better implementation. And so our strategy, and I hope all of our colleagues that have been involved in this would agree, is we like to fully engage with practitioners, not limit this to researchers. We focus on building networks that practitioners also value, so that we can together take a continuous learning approach to our implementation and evaluation activities. So for us, this is more of a participatory form of research, where we are also learning from those who are delivering care. And Matron Margaret talked about listening to the people on the ground and sharing good stories of what works, and that those are the beginnings of networks. So it is important to give people time to get together, to reflect and identify the issues that concern them, and also therefore the deeper issues that are underlying many of the problems. And the example I gave you in the story before is one such example of an organizational issue where if nobody is willing to volunteer that there's a problem or that they have a worry, then worries will not get addressed. So much of our job is to be learning coaches, if you like, to learn together with practitioners, to give people the space and time to do the thinking that is actually the research. So for us, we feel sometimes that quality improvement is too often reduced to using run charts or some other tool. And if people essentially use the checklist, run through the processes, that they're doing quality improvement. And that's a very superficial view of quality improvement. And I know many of my colleagues would agree. So quality improvement includes many of the things that Matron Margaret was talking about. It's the supportive supervision, it's mentorship, it is the learning, and it's building these communities of people interested in improvement. So all of these things also are done in specific contexts, and we can't ignore the fact that different contexts have different challenges. So the reason why it's so important to learn with practitioners is they understand and they're part of the reality. We can't just take a single way of doing things from one country and put it into another. So for us, I think the philosophy is that implementation research has been more like action research. But let me pass back, Anshu.
Thank you. Thank you very much, Mike. And maybe we can hear from Grace. What do, for example, in her department, the hospital staff really want to learn at their individual level to improve their practice? Do they see quality improvement as a day-to-day priority? Do training institutions equip people with the skills needed for continuous improvement? Grace, over to you.
Yeah, thank you very much. Greetings from Kenya. I'm here to represent the many Kenyans who have done a lot of work, which we have been publishing. As to whether the hospital staff want to learn at individual level, I think they want to learn, but they want to learn what they don't know. So in that case, then we need to provide alternatives so that they can know what they don't know. And the alternative we provide then needs to be something they can see the results, something they can reason out logically, and something where we can present scientific evidence that the results can happen. So for them to accept, to change from what they have been doing, there must be something better. They must be convinced that something which you're introducing to them is better. For example, even taking something simple like the correct use of technologies like radiant trauma, we found that before our training, we would find babies are called on the radiant traumas and the radiant traumas are on. And when we train people on how the radiant trauma works, how to operate the radiant trauma, how to select the right mode, and how to connect the baby to the temperature sensor, then people could see, yes, the radiant trauma generates just enough heat for the baby, and we stopped having cold babies. So when they see results and they understand how an intervention works, then they would like to learn more. However, for them to put whatever they have learned into day-to-day practice, you need champions. Because once you train people, actually after about a month or so, you find they're doing just what they were doing before. So to sustain that improvement, you need champions. And these champions need to be people who are ready to read more than the other people they are mentoring, and also who are able to read the WHO papers, because there's always emerging evidence, so that they can keep up to date. So for us, the next champions, our champions, we train them through the generic instructors course so that they can be teaching the people even after the training. And then we also train them on how to read papers, simple materials in the WHO website. We train them how to look for the materials there so that they can keep up to date. So I find without champions, you find there's knowledge decay.
So, thank you. And maybe I can ask you a follow-up question. So one is, of course, for the individual staff to improve their own capacity. but what are the lessons that you can share about linking learning from the maternal newborn health quality improvement implementation, linking it up with management and decision-making processes at the facility and district level?
Yeah, so thank you very much. So for people to learn, then they need to look at, to reflect on their current practice. So learning could be learning wrong things or could be learning good things. So for people to learn the correct things, they need to know what are the alternatives of any intervention. And as I mentioned earlier, to have evidence that that intervention is better and even be able to see the results. But then they also need to be able to reflect on that. And the best way for them to reflect on that is by doing audit. However, for them to do audit, they need to have knowledge in terms of best practices, so that they can actually look at what care has been provided and the gap between that care and the best practices. Then for them to be able to learn from it, they need to identify problems in the care provided, and also feasible solutions in that context. So we find that problem identification, as simple as it looks, it's a big challenge. And this is a skill which you don't even teach in most of the medical schools. And beyond that, there is the root cause analysis, which is another big problem, so that you find when they have not identified root cause analysis, they'll just identify the problem and come up with a solution, which is a linear solution. So for example, if it's the newborn unit which is congested, the solution will be to expand the newborn unit. Well, actually, the solution, if you take root cause analysis, it could be improving the quality of care, could be improving the referral system, could be just having a discharge and admission criteria. So you find that learning will occur, but then they need to reflect. And for them to reflect, there has to be best practices, which they are aware of, and they have to have the data which they are going to use retrospectively to know how the kind of care which was given. Unfortunately, in our setting, data is not good. So you find the data which is there, can't tell you whether the diagnosis of the patient was correct or whether the treatment given was correct, because they are missing variables. So one of the steps for learning, one of the initial steps for learning is to have good data, and then to have guidelines which will inform people the best practices, so that they can compare the care given with the best practices, and then see how they can fill up that gap of care.
Thank you. Thank you, Grace, and particularly for highlighting that issue about data. Regular use of data to track progress and to identify areas for improvement is a core principle of quality improvement that paves the way to progress. So Kathleen, can you maybe share from your perspective your learnings from efforts to strengthen routine measurement systems, such as facility registers or patient cards, etc., to collect, report, and use quality of care indicators to help improve and sustain quality maternal newborn health care?
Thank you very much, Anshu, and it's a privilege to be a part of this panel. Many thanks for including me, and warm greetings to my fellow panelists and to participants around the world. I'd like to highlight several challenges and opportunities for strengthening routine maternal and newborn quality of care measurement systems for the purpose of improving care for women and newborns. And my comments really come from my engagement in several large-scale country efforts to improve quality of maternal and newborn care. In many of these efforts, I've worked with several of you on the panel, and it's been an honor. And also my comments come from my engagement in the Network for Improving Quality of Maternal Newborn Care, in which many of you are involved. First, let me begin by saying that regular measurement is a core principle of improving quality of care, along with iterative action to change the status quo, and is essential for learning, continuous learning, for governance, for decision-making, as has been highlighted by my fellow panelists. And I think we would all agree that having data is just essential to being able to support these broader, efforts to continuously improve quality. We know that fit-for-purpose routine quality of care measurement systems are important because they provide reliable sources of data for monitoring trends in quality measures in real time to identify areas for improvement, to monitor whether or not care is in fact improving in the context of quality improvement efforts, and to monitor whether quality of care is being sustained once improved through quality assurance mechanisms, et cetera. And we know that routine sources of health information data may include service delivery data at the level of facility registers, patient cards, as well as service delivery data that's aggregated across facilities, for example, in a district health information system, as well as other kinds of administrative data, logistics management information systems, and very importantly, measures and feedback from clients. We don't have time to get into this, but this was really highlighted during yesterday's sessions on respectful maternity care. One common challenge for routine quality of care measurement is the relative paucity of measures of quality of care. For example, the proportion of women whose blood pressure or hemoglobin was checked during ANC, in addition to data on the number of ANC services provided. In recent years, many countries we are seeing, certainly through the network and other efforts, are increasingly incorporating measures of quality of care into their routine measurement systems. However, the question, in my view, of which quality of care measures should be included in a routine quality of care measurement system is not a trivial one, and is one that perhaps we don't spend as much time as we could thinking about, despite many efforts in this area. I think that deciding which measures to prioritize requires very careful consideration and close engagement of clients, frontline health workers and managers, as well as experts in quality improvement health information systems and maternal newborn health. From my perspective, a challenge and an opportunity is to find the sweet spot between too little measurement and too much measurement that we know carries many opportunity costs for healthcare workers that are already overburdened with endless documentation. Think of the midwife in the clinic with piles of registers. Ideally, we would hope that quality of care measures can span multiple quality domains, including, importantly, people's experience of care, but also equity of care for marginalized women and newborn, in addition to measures of effectiveness, of safety, of doing no harm, and of coordination of care. And this is no small order. We know, fortunately, the prioritization of quality of care measures for maternal and newborn health has been a strong focus of recent and ongoing global and country level efforts in recent years. And I encourage participants to explore the references on the Align MNH website, as well as the Quality of Care Network website, including the monitoring framework for the Quality of Care Network, which really dives into these issues in much greater detail, as well as some recommendations for quality of care measures. Two other common areas of challenge and opportunity, which I would just like to briefly highlight before closing, concerns the quality of the data that is recorded. And I think my co-panelist, Grace Iramu, reference the issues around quality of data, and also the competencies of managers, health workers, and clients to use quality of care data to improve and monitor quality of care and identify areas for improvement. Just as health workers are needed that have the clinical skills, we also need health workers who have the skills to be able to prioritize, to measure, and to use the results of quality of care measurement for the purpose of learning, for the purpose of governing large-scale quality projects, and for the purpose of continuously improving care at the front lines. I don't have time to go into these details in depth, but Fortunately, this is a topic that is really getting a lot of attention in many countries, as well as at global level. And I do encourage participants to reference the resources on the Align MNH, as well as the Quality of Care Network website, and would also refer my participants to the first session in the Align MNH April Collective that looked at some of these issues as well in greater detail. Thank you so much, Anshu.
Thanks, Kathleen. Could you just say one thing, and really in 30 seconds, about the role of MPDSR, or maternal perinatal death review and surveillance, in relation to improving quality of care? Very quickly.
Yes. Thank you. I'll try and be very brief. This is a topic that's also getting a lot of attention, and was actually the topic of a side session at the most recent in-person meeting of the Quality of Care Network, which then led into the development of a brief on this topic. And I'll just highlight two issues. One is I'll begin by saying that MPDSR, when done well, generates essential information on the most common causes of maternal and perinatal deaths and the key contributors to these deaths in a local setting, including contributors related to poor quality of care. And this information can be very valuable for informing forward-looking quality improvement efforts. For example, if audits of maternal deaths in X district demonstrate that, a common reason for deaths is postpartum hemorrhage, and that a common reason for the deaths due to postpartum hemorrhage is failure to monitor women closely for bleeding after birth and to initiate immediate treatment, quality improvement teams can actually work on those issues and monitor measures to know whether or not care is improving. And they can take the recommendations from death audits, which often are not systematically implemented and are not monitored on a regular basis. And they can actually implement and test these recommendations that come from audits to determine whether or not the recommendations are actually yielding the results that are hoped for. There are several publications that have been published recently in this area. And I think one thing to highlight is that we know in many countries, particularly for maternal perinatal death audits, that structures and processes related to MPDSR and quality of care have often developed in parallel. We see that many countries are now looking at ways to better align the work of MPDSR and quality of care committees and processes. For example, in Nigeria, several states are now combining these committees. And I think that this is an area where we can learn a lot across countries and hopefully can continue to explore next year's conference. Thank you so much.
Thank you very much, Kathleen, and for all of you for your contribution. I'll maybe quickly summarize what we got from the Padlet activity. And the question that we asked was whether you could list some critical actions health systems must adopt to ensure essential quality maternal newborn health services to continue in face of crises. And according to the LALA framework, the Leadership, Action, Learning and Accountability framework, what we have heard from you is, first of all, on leadership, really to focus on domestic commitment, let's say, both from a funding perspective in order to support quality of care nationally, as well as from a government ownership and leadership perspective, also to align partners to harmonize their investments around the quality of care and to prioritize and fairly compensate human resources. Human resources was highlighted a couple of times by the speakers. Around action, it is really around fostering a culture in quality of care between health managers and frontline health workers, but also to utilize professional associations to implement this. When it comes to learning, it's very much around flexible capacity building approaches, peer-to-peer, or remote learning, including within pre-service education and sharing of lessons learned, but also between countries and across quality of care network countries. When it comes to accountability, it's really looking at how to engage communities and key stakeholders in designing, implementing, and using the data to improve quality of care, and also to develop and strengthen data systems that has been just highlighted as well. So having said that, we've seen that the views of the audience on actions for health systems must adopt. And maybe we can have a couple of reflections from our panel's members to reflect on some of these comments that have been made around the LALA framework, the learning, action, the leadership, action, learning, and accountability. So maybe, Margaret, can I go back to you first, Matron Margaret, for a quick reflection on how this could be on some of the comments from the audience.
Thank you very much. In terms of reflections, as I sit here and my colleagues were actually presenting, one of the key things around the LALA framework that's really enhanced was when they mentioned about the pool funding and also galvanizing partnership buy-in in terms of leadership and also the political will. I am having a lot of support from directors and even within the Ministry of Health and Sanitation as I speak to you. For me to really have dedicated salary workers in terms of human resources, because initially when we started, you do capacity building for quality of care and quality improvement. But by the time you go again, the staff has been either transferred to other place or posted somewhere. And like Gaga said, then we had a lot of volunteers. And thanks to the ministry, when they realized that volunteers are not very committed in terms of doing the job, what the ministry did was to do a recruitment of about 3,000 midwives, so and health workers, specifically nurses and midwives. So today, all of them now are on salary. So a lot of a commitment is coming out from them. And if you go to like the special baby care unit, there is no sitting actually. So it's like they are all on their toes because of that one little push. In terms of like action, where we really have to ensure that there is a lot of accountability, we are trying to build partnership. So I had new people who came on board. Initially, the support was from mainly the UN agencies, that's WHO and UNFPA. But when we had the Momentum Global Leadership, the MCGL, with funding from USAID, that actually brought in, and we were able to use that particular one to scale up quality of care in 53 additional facilities. And in terms of learning, the learning sessions were supported also from these partner funding, where we went to all the districts and all the facilities, they came together. That wouldn't have been possible if there was not a lot of partnership buy-in and also funding. In terms of engaging community, that's where I would really want to embark on. Like Dr. Hill said, respectful maternity care needs commitment. So these are some of the trajectory that I would like to embark on so that we mainstream RMC within our quality of care, where people need to be treated with dignity, respect, and compassion. Because in this part of the world, we have actually ratified global treaties and protocols, but domesticating it, really making it functional in Sierra Leone is something that is key. So moving forward, perhaps we want to have respectful maternity care and also client charter, where they are clearly informed, community are clearly informed about the roles, the responsibilities of facilities, and they are given opportunity to give independent feedback on what services they are receiving at facility, and also feedback on health worker attitudes and behavior. So
thank you very much, Matron Margaret. I would like to move to the next speaker. Maybe Gagan, maybe you'd like to reflect on some of the comments made.
Right, thanks, Anshu. I'll just be very brief. To me, the most important thing is the strong government leadership and the partner alignment with national priorities with sustainable financing. It needs to be one country, one plan, one budget. No multiple projects going on depending on the partner priorities, but everything aligned and pulling into the national pool and the national priorities. And this should be driven strongly by data to ensure the quality is along with the coverage. Second important thing I would also like to bring is use COVID as an opportunity. Though COVID has been a roadblock in progress, but also COVID has got the highest attention of the government and policymakers to the health. And many issues which were pending and which can affect quality, like infrastructure, the WASH, the infection prevention control, the lab support, the radiology, the human resources. There is a huge buy-in which was never before to fix all these things. And we should use COVID as an opportunity to fix the gaps which can hinder quality on the ground. That's it from my side. Thank you.
Thanks a lot, Gagan. Maybe Mike, you would like to go next.
Thank you, and I enjoyed the comments and the previous contributions. Maybe just to build on Dr. Gagan's point, clearly I absolutely agree, and I think Matron Margaret said this as well, it needs central government leadership, needs alignment across partners, and therefore it needs alignment of the resources. My addition to that would be, it's not just good enough to have national leadership. The leadership must be in a form that we call distributed, where people right down in the facilities are also able to take leadership, able to take ownership of quality improvement. But to do that, they can't just be delegated a responsibility. They have to be delegated some ability to act. They have to be delegated some resources. And nothing kills a project quicker than the people on the ground failing to do something that they see as critical. I've seen a project fail simply because a hospital was unable to print a piece of paper that would help them do a better job of referring patients. So we have to have a delegation of resources as well as responsibilities. And maybe just one other thing to add is that accountability is critical and data are really important for that. But accountability can be dangerous if it's not handled correctly. If it turns into blame and makes people feel guilty, then you will lose all of the trust you have and your quality improvement program will fail. So they're my hopefully useful contributions. Thank you, Andrew.
Thank you, Mike. And particularly that blame culture has also always been a stumbling block with MPDSR, let's say. Grace, maybe over to you for some reflections on what we heard from our audience.
Yeah, thank you. Yeah, so we've talked about the evidence-based evidence-based policies, but I think for leadership, there's also need to build capacity among the leadership so that they're able to see the maternal and the newborn component, the maternal and newborn as one component, other than seeing them as fragments of different domains. And this is, for example, if we have a problem in the newborn unit, the problems you have actually in the newborn unit, they are mainly preventable in our setting. We need the preventive measures instituted in the maternity, in labor ward, during childbirth, during antenatal period. And so if we are going to have solutions for the newborn unit, and we just focus where we have caffeine, we have the other things just for the newborn unit, even if we are taking a problem like preterm deliveries, the solution, we need the leadership needs to have that capacity to see the whole, other than the fragments of the whole, so that even when it comes to resource allocation, be able to actually just realize that we need to engage the community, we need to engage the maternity, antenatal and maternity, and we need also to solve the problems in newborn unit, other than delivering solutions in the newborn unit. So the complex system thinking, I think, is a key issue, and so that we avoid having linear solutions. So that if we have preterm deliveries, direct solution is KMC. KMC Kangaroo Mother Care should come also with preventive measures for preventing preterm deliveries. If it's asphyxia, we should also have component for preventing the intrapartum related complications, because our problems in the low-income countries are mainly, they can be prevented, And therefore, a lot of focus should actually be on prevention, even as we also put resources in solving the problems which are as a result of negligence, or the things we have omitted in the earlier pathway in maternal and community and earlier on. Thank you.
Thank you, Grace, and also highlighting that complications between maternal health and newborn health are so closely linked to each other. Kathleen, maybe you be the final panelist to reflect on what we've heard.
Thank you very much, Anshu, and very much agree with all the themes highlighted by my fellow panelists. I think, in fact, that the themes that we've been discussing throughout this panel, the importance of strong leadership at all levels, at national, subnational, facility, service delivery, the importance of human resources that feel that they are working in an environment of trust and that they are able to actually make the changes that they need, and as well as the importance of data systems are essential for being able to be resilient in the face of a crisis. And, you know, I was struck the first panel on the first day of this wonderful April Align MNH Collective had some really powerful examples, particularly one from Uttar Pradesh of, you know, large scale, rapid sort of pivoting of a health system in the face of the COVID crisis, and the use of data to know which services were being interrupted, et cetera. I think that we have perhaps less information about how quality of care has been affected during COVID. We have more information on mortality, on service delivery disruption, but perhaps less on quality of care. So I think that all of the themes that we're discussing today around strengthening routine information systems that tell you about the quality of your care that you can use during a crisis to rapidly make decisions, as well as having created structures of leadership and continuous learning that are part of a health system, those become incredibly important mechanisms for being resilient in the face of a crisis. So I really see all of the themes that we're discussing today around leadership, governance, action, data systems, learning, continuous learning, as being at the center of being able to be resilient in the face of a crisis. So those are my comments. Thank you very much, Anshu.
Thank you very much, Kathleen. And I would really like to thank all our panelists for this thoughtful and critical conversation and really highlighting the different areas around quality of care and quality improvement that we need to address, whether it's at the national level, at the district level, or at the community level, how to involve the different levels and different cadres in this, the issue around financing, the issue around data, etc. So we're eager to continue this conversation and are particularly looking forward to continuing to explore these themes together at the International Maternal Newborn Health Conference, or the IMNHC, in May 2023, next year. And in 15 minutes from now, we will have the launch event for this conference, and we encourage you to join to learn more about the conference goals, its objectives, the different tracks, and more. We hope you'll be able to join us for this exciting moment. The recording of today's event will be posted on the Align MNH Knowledge Hub, and that will be on alignmnhaltogether.org, where you will find also a collection of key resources on all the topics that we have discussed today. Related resources for this session can also be found on the Resources tab within this very same platform you are joining on today. We value your opinion and would like to hear your feedback. A brief 5-question survey will appear on the session page where you're watching this video. Please scroll down and complete the survey, and be sure to hit submit to ensure we receive your feedback. It's been a pleasure having all of you join us for this critical and timely event, and we know that this is one conversation of many to come, including in the lead up to the IMNHC 2023 conference. Thank you very much for joining us today.